So first, just like I'll ask you questions. Just respond to them in a way as if um, people don't know what the question is, so that it makes sense when you start talking about stuff.
Okay.
So first, just introduce yourself and what you do.
My name is
You can
Alan.
just look at me. Yeah.
My name is Alan Pope. I'm a physician at Our Lady of Lourdes Hospital. I practice pulmonary medicine and critical care medicine.
Well, why have you chosen to practice at Lourdes, and what is it that you like about working in Camden?
I like practicing at Our Lady of Lourdes because it gives me an opportunity to do a lot of different aspects of medicine. The hospital provides tertiary care. We take care of a large number of patients with cardiac diseases, including various open heart surgeries. We're one of the designated cardiac centers in the area, have one of the larger volumes in the area. We also do transplants. We have liver transplants and kidney transplants, and because of that we have a pretty high acuity of care. Also have the opportunity to do teaching because we're affiliated with one of the medical schools, so I regularly have medical students and residents with me and fellows with me. And all of that gives me an opportunity to do different things in medicine. Camden's sort of unique in that it's one of the poorest cities in the region, if not the country. So we do a lot of indigent care. We also provide for a lot of people in the community. So it's a nice mix of patients.
And where do you spend most of your time? Like in what areas of the hospital, working with what kinds of people, doing what kinds of procedures?
Yeah, I work on the general medical surgical floors as well as the critical care unit, and I take a rotation in the critical care unit where we work as intensivists. As intensivists, we see the sickest patients in the hospital, the ones that may be having a massive heart attack, that have kidney failure, that have liver failure, that have respiratory failure and require a mechanical ventilator for us to support their breathing. In addition to that, I do see people on the general medical floor where I provide consultative services for patients that have respiratory diseases. Could be something like severe emphysema, bad pneumonia, those types of illnesses.
That's really good. How has medicine changed over your career?
Medicine has changed pretty dramatically over the years, both in the availability of what we can do as well as the way we deliver it. I was at a dinner with a contemporary who's a physician the other night, and he was telling me how he recently gave a talk to the medical students for UMDNJ, University of Medicine and Dentistry for New Jersey. And they had quite a few laughs because he was talking about how when he started out there were no CAT scans, and that was true for me. CAT scans were just coming into vogue back then. We didn't have MRIs. We didn't have a lot of different scans that we have. A lot of the cardiac things we can do these days, like put stents into arteries to open them up, use lytic agents, which are agents that dissolve blood clots when somebody comes in with a heart attack or with a stroke, are things that weren't available. Many of the antibiotics that are now available weren't available back then. So there's a lot of both diagnostic things we can do as well as therapeutic tools that we have available now that we didn't have before. The delivery system is also changing. There was no managed care when I first came out of medical school. People had insurance. They came and they either paid the bill or they offered their insurance, and we took whatever they had for insurance. Nowadays, with managed care, a lot of the insurance companies are more involved in care in terms of telling physicians what they feel they can access for studies or for therapies. There's been a lot of changes over the years, and it's interesting that you should ask that, because if you go to a physician that maybe is up in their '80s, you'll get some people that'll tell you that they first saw when antibiotics became available. And it's almost hard to comprehend practicing medicine these days without thinking that you had antibiotics to use, and even ventilators to use to help people with breathing. For instance, that's something that started in the mid-century, last century.
Good. A lot of stuff to use there. Why did you choose to go into medicine in the beginning?
I think medicine was attractive for a number of reasons. One is intellectually stimulating. There's a lot of science to it, and I enjoyed science. There were always new things coming out, which makes it stimulating and challenging. Every year there's something new to learn. There's just countless amounts of research that are produced each year that improve upon what we can do. And I think that's really what got me interested in it at first. And it's very satisfying, to go see a patient and see them get better is very fulfilling. To see the families, that interaction and how, and their appreciation, I guess, of what is done as well, if when their family member improves, somebody who's really critically ill. Those are things that make it very attractive and continues to be very attractive.
How is practicing medicine and how is the critical care unit and just being a doctor in general different from what people tend to see on TV?
Although there is humor, there's not quite as much humor as you're going to see on a lot of the different shows. And I forget the shows that are on now, but if you think of House would be suspended from the medical staff within about 5 minutes. The way he interacts would never be allowed within a hospital setting. I mean, he just does multiple things every day that wouldn't be allowed. Nor could anybody practice that way, even if they had better social skills than he did. They wouldn't be allowed to be, doing surgeries and all these other procedures that he gets involved in. It just wouldn't happen. And I forget there's another show on which is where everybody's sleeping with each other, and that doesn't go on around here as well. It's a lot different in those respects.
Good. That's a good. Those are all my basic questions. Anything else that you think might be particularly interesting or pertinent, or somebody outside the medical community you think of?
You can ask me what are some of the challenges medicine's facing?
Yeah, what are some of the challenges, and also what's the environment like on the critical care unit day to day?
Let's do one at a time.
Yeah.
First, what are the challenges? The challenges that we see for medicine going forward are probably largely related to how much money is going to be available. The percentage of money that's spent for medical care in the United States as a portion of our gross national product is higher than any place else in the world. We do provide good care, and you'll find that people come from all over the world to seek care here, people that can afford to do so. Technologically, we're overall the most advanced country. And although there are issues with availability of services, whether we can provide services for everyone, I think we still obviously don't do a great job for the indigent and for the poor. Hospital services are available for all Americans. Anybody who comes into a hospital is going to be cared for and get what they need. We need to find ways to provide care for these individuals outside of the hospital, so we can provide care for them in an outpatient setting at a way that's less costly and still provides the care for everyone in an equal and just fashion. And unfortunately, as we spend so much on medicine, it's affecting our economy. So somehow the government, the insurance companies, the American people are going to have to come to grips with how can we afford to provide the best care and provide it for everyone. That's a tough task. It's not an easy thing to do, and it's really a long discussion. But it's one thing that we need to face going forward.
Do you think that within the next 10 years or so that there will be a universal health care policy in America?
I think there will be universal health care. I would be surprised if there is not. But it may not be one health care plan. Nearly all the elderly now have a Medicare plan, which is fairly uniform. There's some nuances in individual type Medicare plans and supplementary plans, but basically the plan is given by the government, it's universal, it's fairly standard. I don't think we're going to see that for everyone. I think that it's too tough politically to do that. There's a lot of big insurance companies out there that are involved in health care. But I do think that there is going to be a movement toward universal health coverage. There may be a menu of plans. Some of them may offer a little bit more than others. Some people may need to pay for more than others. Some of them may be a Rolls-Royce plan where you get a little more attention. But I really believe that we need and will have a plan that will provide basic, good, acceptable coverage for everyone, whether you can afford to pay $1 or $1 million for it. I think that's something that the people are coming to expect. I think as people are beginning to believe it's a basic right, and I know all of us in healthcare feel that it's important. And it's even important from an economic standpoint. Keep the population healthy, the economy is going to do better. So I mean, you can think of it in terms of dollars, in addition to just thinking what's right, what's best to do for people.
Good. What is the environment like on the ICU, and is it like a high-paced environment? Is it a stressful environment? What's the general?
The critical care units are a very collegial place, and one of the reasons for that is we work with few patients. There's a few doctors that are there all the time, particularly the intensivists, as well as some of the consultants, cardiologists, nephrologists, pulmonologists, neurologists, whatever. The nurses deal with one or two patients. The families are there a lot because they're worried about their very sick family members. And as a result, there's a lot of collegiality, particularly among the staff. We interact a lot more, we're there a lot more. Because of that, there's an opportunity for knowing people better, a lot of humor, but on the other hand, it gets very intense at times. People are very sick down there. It's stressful for the physicians, it's stressful for the nurses when things aren't going well, when patients aren't doing well. Families want to know what else can be done. Is there something else that could be offered? What else can be done? So when people are really sick and not doing well, when they're deteriorating, when you think you're trying to do everything you can and they're not getting better, that's very stressful for the staff, and there can be a moderate amount of burnout, if you will, in some of these units because of the fact that it can be so intense. On the other hand, when things are going well, when people get better, when you see that patient that you thought was going to die, who comes walking into the hospital, a couple months later, it's very fulfilling. Just makes everybody elated, and you feel that, for all the hard work you put in and for the few that you lost, those people that you saved, it really touches the staff. So, it can be an intense environment. I think there's a lot of strong emotions. Sometimes the emotions are that people are upset. Some are when people are doing well, when you pull somebody out of the fire that you didn't think was going to get better, it's a real rush. So it's an intense environment, but a collegial one.
That was really good. And lastly, can you just tell me about your practice in the office in Cherry Hill?
Yeah, my practice is, although I spend more time in the hospital, I do spend time in an office as well. I see patients in the office with various pulmonary problems. Patients that may have an unusual pulmonary disease or a difficult managed disease. I don't see patients like basic asthma or basic emphysema unless they're patients that are very difficult to manage. I may see patients that come in with a new spot on their lung that we find is a lung cancer, or some more esoteric disease like sarcoidosis or bronchiolitis obliterans, or one of many unusual diseases that the average doctor wouldn't know what to diagnose, or how to diagnose this, or how to treat it, or didn't have experience in treating it. The remainder of my time is in the hospital, and in the hospital I, again, in addition to making rounds in the critical care units and on the general medical floors, providing consultation for patients, I do have some administrative roles. I'm involved in teaching. I'm involved in performance improvement for the physicians in hospitals. We're always looking to do things that we can do better, create systems that make the process work better. And involved in some planning for the Department of Medicine. I'm chairman of the Department of Medicine, so I'm involved in planning new programs, developing new programs as well.
Cool. That was great. We got a lot of really good stuff there. Well, obviously I have to cut down, but that was really good.
Okay, then why don't we, should we quit, and if...
Just probably won't use it. Yeah.
All right. What do you want to do first? You want to go...
Wherever.